Hi everyone, my name is Melissa Moss and I am a third-year student pharmacist at Cone Health. Today I will be sharing pharmacy updates for the month of August 2022. In this video I will be covering the SURMOUNT-1 trial which studied Mounjaro for weight loss in patients without diabetes. I will also discuss a new FDA approval for the drug Auvelity to treat major depressive disorder. Next will be an overview of MonkeyPox and Cone Health guidance on the use of TPOXX. Finally, I'll talk briefly about some influenza updates for this fall. The SURMOUNT-1 trial was published in the New England Journal of Medicine on July 21, 2022, and it studied Mounjaro, or tirzepatide, once weekly for the treatment of obesity in adults. Some quick background on the drug: it is a dual glucose-dependent insulinotropic polypeptide, or GIP for short, and a glucagon-like peptide receptor agonist, or GLP-1. GIPs stimulate insulin secretion when in a hyperglycemic state and suppress glucagon secretion in hyper and euglycemic states, delays gastric emptying, and decreases appetite. These separate effects work together to reduce body weight. Mounjaro was approved back in May of this year for the treatment of type 2 diabetes. It is administered subcutaneously once weekly, similar to other GLP-1 agonists such as Trulicity and Ozempic. Mounjaro is initiated at 2.5 milligrams and increased by 2.5 milligrams every 4 weeks to achieve better glycemic control, with a maximum dose of 15 milligrams. The SURPASS-2 trial is another trial with tirzepatide, which demonstrated superior A1C lowering and weight loss with tirzepatide compared to semaglutide or Ozempic. The purpose of the SURMOUNT-1 trial was to evaluate the efficacy and safety of Mounjaro in adults with obesity or overweight who did not have diabetes. The SURMOUNT-1 trial was a phase 3 trial conducted at several sites across 9 countries. Participants in the trial were randomly assigned equally to 4 different treatment groups: tirzepatide 5 mg, 10 mg, 15 mg, or placebo once weekly for 72 weeks. The treatment was done in combination with lifestyle interventions. After the 72-week treatment period, participants who had been without prediabetes at randomization proceeded to a 4-week safety follow-up period. Those with prediabetes continued in their original treatment group for an additional 2-year trial treatment period. The sample size of 2,400 participants provided a power of greater than 90% to demonstrate superiority of tirzepatide to placebo. Some of the key inclusion and exclusion criteria are listed here. Of note, all participants had a BMI greater than 30 or greater than 27 with at least one weight-related complication. Participants were excluded from the trial if they had diabetes or had a previous surgical treatment for obesity. After exclusion, there were 2,539 participants total, with key baseline characteristics listed here. Notably, participants had a mean weight of 105 kilograms and a mean BMI of 38. 40.6% of participants had pre-diabetes at baseline. The primary endpoints of the trial were the percentage change in weight from baseline and a weight reduction of 5% or more. As you can see in this graph of the overall percent change in body weight from baseline, all of the 3 tirzepatide treatment groups had a significant decrease in body weight from baseline, with the percent reduction increasing with the dose. When compared to tirzepatide 15 milligrams, the change from placebo in the study was 17.8%. A similar trend can be seen in this graph showing the percentage of participants who met weight reduction targets. Even on the lowest dose of tirzepatide, 85% of participants met the body weight reduction target of 5% compared to 34.5% in the placebo group. Additionally, 95% of patients with pre-diabetes at baseline reverted to normal glycemic levels at the end of the 72 weeks, while only 62% in the placebo group reverted to normal glycemic levels. Mounjaro is currently only approved for use in type 2 diabetes, but expect an indication for weight loss to be approved in the not-too-far future. Until then, it is a great option for patients with type 2 diabetes who desire greater weight loss benefit. Of note, only 3 strengths of tirzepatide were studied in the SURMOUNT-1 trial, but there are actually 6 available strengths, as seen here. In summary, all 3 doses of Mounjaro demonstrated substantial and sustained weight loss in patients with obesity. The weight reduction seen with Mounjaro surpasses other GLP-1s currently on the market, although no direct comparisons can be made. The most common adverse effects were gastrointestinal, however they were transient and mild to moderate in severity, and occurred primarily during the dose escalation period. Similar side effects were seen between the 10 and 15 milligram groups. The reported incidence of cholelithiasis was similar among the tirzepatide and placebo groups. Cholecystitis and acute cholecystitis were reported more frequently in the tirzepatide groups than in the placebo group, although the incidences were low. Now we will discuss Auvelity, which was recently approved by the FDA with a breakthrough indication to treat major depressive disorder. Auvelity is a combination of dextromethorphan and bupropion. Auvelity is the first orally administered product with a novel mechanism of action to enter the major depressive disorder market in more than 60 years. Dextromethorphan is an NMDA receptor antagonist and is found most commonly in cough syrups like Robitussin. Bupropion is a dopamine and norepinephrine reuptake inhibitor. It is also an inhibitor of CYP2D6, which is used in this new drug to increase the effect of dextromethorphan. The most unique characteristic of Auvelity is its rapid onset, especially when compared to first-line agents for depression such as SSRIs, which need several weeks to see improvement in mood. There is a significant unmet need for pharmacotherapies that can demonstrate rapid antidepressant effects in major depressive disorder. The Gemini trial was a Phase 3, 6-week, double-blind, placebo-controlled trial to assess the safety and efficacy of Auvelity in patients with moderate to severe major depressive disorder. The primary endpoint of the Gemini trial was a change in the Montgomery-Åsberg Depression Rating Scale, or MADRS score, from baseline at week 6. The Ascend trial was a Phase 2 pilot trial which compared Auvelity to bupropion alone. It had the same primary endpoint as the Gemini trial. The MADRS score measures the severity of depressive episodes and is scored on a scale of 0 to 35, with a higher score equating to more severe depression. In the Gemini trial, Auvelity demonstrated a statistically significant mean reduction in the primary endpoint on the MADRS with a total score of 7.3 points, compared with 4.9 points for placebo at 1 week from baseline. In the Ascend trial, Auvelity demonstrated a significantly greater reduction in MADRS total scores than bupropion alone. Additionally, at week 6, the percentage of subjects achieving remission was 46.5% and 16.2% in the Auvelity and bupropion groups respectively. Both trials only included patients with moderate to severe depression and excluded patients with treatment-resistant depression, defined as failure of at least 2 antidepressants. This graph visually depicts the results of the Gemini trial, showing a greater reduction of MADRS over time with Auvelity, which is the blue line, versus placebo, the red line. The most common side effects seen with this medication include dizziness, headaches, diarrhea, somnolence, dry mouth, sexual dysfunction, and hyperhidrosis. Auvelity was also not associated with any weight gain. However, there is currently no published literature on sustained benefit in depression with this medication past 6 weeks. Auvelity should be avoided in patients with uncontrolled hypertension or a past medical history of bipolar disorder or mania. Auvelity is contraindicated in patients with bulimia, anorexia, or a history of seizure disorder due to a higher incidence of seizures in these patients. It is also contraindicated in patients who have taken an MAOI in the past 14 days, or patients who are undergoing abrupt withdrawal from benzodiazepines, alcohol, or antiepileptics. Auvelity can be taken with or without food. The starting dose is 45 milligrams of dextromethorphan and 105 milligrams of bupropion in 1 tablet in the morning, and after 3 days, the dose is increased to 1 tablet BID, taken 8 hours apart. In summary, Auvelity is approved for major depressive disorder with a breakthrough indication due to promising results demonstrating rapid symptom improvement. It is anticipated to be available at the end of this year. Auvelity's niche is as a rapid-acting antidepressant with significant effects seen at 1 week versus 4 to 8 weeks with other antidepressants. There is currently no evidence to support the use of Auvelity in treatment-resistant depression or used in combination with other antidepressants. The abuse potential hasn't been studied in humans, but there have been reports of patients abusing dextromethorphan due to its NMDA mechanism of action. Next, we will discuss signs and symptoms of monkeypox and how it is transmitted. Also, the drug tecovirimat, which is approved through compassionate use to treat monkeypox, and the Jynneos vaccine for the prevention of monkeypox. Monkeypox can spread to anyone through close, personal, often skin-to-skin contact, including direct contact with monkeypox rash, scabs, or body fluids from a person infected with monkeypox. It is also possible to get monkeypox from infected animals, either by being scratched or bitten by the animal or by preparing or eating meat using products from an infected animal. At this time, data suggests that gay, bisexual, and other men who have sex with men make up the majority of cases in the current monkeypox outbreak. However, anyone, regardless of sexual orientation or gender identity, who has been in close personal contact with someone who has monkeypox is at risk. So we're seeing the highest prevalence of cases in patients who report having recent unprotected sex, especially with a new partner. Monkeypox commonly presents as a smallpox-like rash, although only with a few pimples or blisters, rather than hundreds as seen with smallpox. The most important distinction between monkeypox and smallpox is that monkeypox is less contagious and causes less severe illness. Monkeypox rash may be located on or near the genitals, but could also appear on the hands, feet, chest, face, or mouth. The rash goes through several stages, including scabs, before healing, and may look more similar to pimples or blisters. Monkeypox rash can be very painful or itchy. Other symptoms include flu-like symptoms such as fever, chills, swollen lymph nodes, headache, and respiratory symptoms. Symptoms usually begin within 3 weeks of exposure, and flu-like symptoms typically develop first, followed by the rash. Monkeypox can be spread from the very first sign of symptoms and may continue to be contagious until the rash has fully healed. Illness usually lasts 2 to 4 weeks total. Tecovirimat, or TPOXX, is not available commercially. It is available by compassionate use from the Strategic National Stockpile. The CDC is responsible for allocation of tecovirimat to state and public health authorities. The Investigational Drug Service has an IRB approved by Cone Health to study the drug, and the IDS service handles all dispensing. Tecovirimat can be used as an empiric treatment for a lab-confirmed or suspected infection of monkeypox based on known exposure or clinical presentation. It can also be used as a secondary treatment for complications following administration of the replication-competent smallpox vaccine. It is reasonable to suggest use of tecovirimat for post-exposure prophylaxis in the setting of a known high-risk exposure or a probable infection. IV tecovirimat is also available for adults and children who are unable to take oral therapy. Patients can become ineligible for tecovirimat if they or their representative are unwilling to sign an informed consent form, if they refuse treatment, or have a known allergy to tecovirimat or its inactive ingredients. The IV form of tecovirimat is contraindicated in severe renal impairment, although the oral form can still be used. Tecovirimat inhibits the orthopoxvirus envelope wrapping protein, which prevents the formation of egress-competent envelope virions necessary for cell-to-cell and long-range dissemination of the virus. Efficacy has only been established in animals, and there is limited safety data for use in humans. Tecovirimat is taken 30 minutes after a full meal containing moderate or high fat. Duration of treatment is typically 14 days, although this duration may be longer or shorter depending on progression of disease and clinical condition, but treatment length should not exceed 90 days. Common adverse effects of the medication include headache, nausea, abdominal pain, and vomiting. Tecovirimat is dosed based on the patient's weight, as you can see in this table outlining the recommended dose for a patient based on their weight in kilograms. Most adult patients would have a recommended dose of 600 milligrams or 3 capsules every 12 hours. Additionally, there are slightly different weight cutoffs for dosing of IV tecovirimat. Prescribing of tecovirimat is restricted to Cone Health infectious disease use only. The list of authorized prescribers is listed here. If you identify a patient who would qualify and benefit from tecovirimat, the patient needs to be referred to ID for prescribing, also for the requisite weekly monitoring. Tecovirimat will be dispensed by the Investigational Drug Service at Moses Cone Hospital, and no other pharmacies in the health system will have a supply. It is very important to obtain informed consent for tecovirimat prior to initiating a dispense of the medication. The Jynneos vaccine is approved for preventing monkeypox and smallpox, and it is available in a limited supply from the Strategic National Stockpile. It can be administered subcutaneously or intradermally and requires a second dose at least 4 weeks after the first. Cone Health does not currently have the vaccine, but is available on a limited basis at the health department and will eventually be administered at the Regional Center for Infectious Diseases once available. The Jynneos vaccine can be administered at the same time as treatment with tecovirimat if necessary. In summary, stay on the lookout for symptoms of monkeypox in our patients at higher risk of contracting the virus, and recommend vaccination at the health department to patients in populations with higher prevalence of monkeypox. Refer the patient to ID to treat with tecovirimat if infection is suspected or confirmed. Importantly, make sure the patient signs a consent form first before referring to ID. Finally, we will cover a few updates for influenza this fall. Flu vaccines for this fall are now available. Routine annual influenza vaccination is recommended for everyone 6 months and older without contraindications, and all vaccines available this season are quadrivalent. The composition of influenza vaccines this year includes those listed on the screen. The strains included in this year's flu vaccine are largely the same as the strains included in last year's vaccine, although the strains in bold on the slide have been updated to the 2021 version of those strains. For patients over the age of 65, a high-dose vaccine is recommended, which includes the Fluzone High Dose, Flublok, and Fluad vaccines. Oseltamivir, or Tamiflu, is the first-line choice of an antiviral for the treatment and prevention of influenza. It is approved for the use as a preventative agent in patients at least 1 year old and is approved for the treatment of influenza in patients as young as 2 weeks. Baloxavir, or Xofluza, is now approved to treat and prevent influenza in patients 5 years and older. The age cutoff has been reduced from the previous cutoff of 12 years. Baloxavir's niche in therapy is as the only single-dose oral antiviral agent approved for influenza and in oseltamivir-resistant infection. In summary, our updates for the month of August included a study on Mounjaro for weight loss in patients without diabetes, a new FDA approval for the drug Auvelity to treat major depressive disorder, an overview of monkeypox and Cone Health's guidance on the use of TPOXX, and a few key influenza updates for this fall. Special thanks go to Pete Koval, Madison Yates, and Rachel Shelley for contributions to this month's updates. Thank you so much for watching. This concludes your August 2022 pharmacy updates.